Thanks a lot. Yeah, thanks a lot, and thanks a lot for the organizers, also for having me to step in on behalf of our quite amazing postdoc Max Briggs, who would have been giving this talk. I don't know what's happening to the UK representation now. I'm the first, I think, today representing the UK. Celia is down with a broken arm, and Meg is also down, and Ben, who's speaking tomorrow, got the wrong plane, but now arrived. So I'm representing the UK, although I'm actually Danish. Apart from when there's the Winter Olympic, then I'm Norwegian. Or Eurovision, then I might be Swedish or whatever. So I will be speaking about some work that we are doing, so not something we have completed. So there won't be many results, and that's why I have expanded it, maybe slightly time optimistically. Otherwise, I'll just have to sprint through, and you'll get stroboscope sliding in the end of it, to also present another study we're doing in chronic pain. Also a bit inspired by this morning that there's interest in that clearly, which is very interesting as well. So I'm a psychiatrist of background, but have been working with imaging for a while as well. So anorexia is, as most of you know, a very devastating condition, one of the most severe, with the worst outcome in mental health. It's about restricting energy intake, leading to significantly low body weight, intense fear of gaining weight, disturbance in experienced body weight, shape, undue influence of weight, shape, and so on. And I won't list how it looks, but it's listed here in the slides that you can get copies of later as well. The lifetime prevalence is 1 out of 200, mainly young females are affected by anorexia. It has the highest mortality rate of all mental health conditions. Suicide rate is 56 times higher than the background population. So it's an extremely severe condition. And for 20 to 30%, it's a lifetime condition. And there are no direct treatments. So the treatments that are used in mental health to treat anorexia, it's a wide range of talking therapies, mainly very cognitive, behavioral-related therapy models. And in terms of medication, used as in tons of other mental health conditions, SSRIs, which I almost find wrong to call antidepressants since they're used for all conditions in mental health. But so it might be more appropriate to label them after how they work, and serotonin reuptake inhibitors. So they are used, but that's also because it's extremely comorbid together with both anxiety and depression. So that might be where it has its main effect. And then sometimes sedative in relation to food intake, sometimes required in patients with this condition, and antipsychotics, which can be used for different adjunct to antidepressant for the mood component, but also because of antipsychotic medications. Now I use the term antipsychotics that are used for mood, so that's equally wrong, but they are typically dopaminergic or serotonin 2A blockers. They increase appetite, so that can have that sort of, the side effects of the drugs can be used beneficial here. But all these treatments are not necessarily going after the core and the depth of what's going on and the background of why people are suffering, the trauma and so on. So there's definitely room for improvement in the treatment of anorexia. And bringing psychedelics into the show here is relevant. They are targeting into the serotonergic system, as you have heard earlier, targeting by agonism the 2A receptor in the serotonin system. The serotonin system is important both for impulsivity, regulation of mood, regulation of appetite. So it's a relevant system to target in the treatment of eating disorder. Also, reduced neuroplasticity has been seen in studies using different measures related to plasticity in anorexia. And as you have heard, some of these compounds can induce plasticity, at least in preclinical models. We are, together with others, including I just saw earlier, very important work done in Sweden, Umeå, with using the UCBJ tracer to actually measure it in humans. We are planning similar work at Imperial. And also other aspects where there's an overlap between the problems in anorexia and the potential mechanisms by which the psychedelics work. There's an early from the 60s, from 59, case study reporting very beneficial effect after an injection of psilocybin. And then also Adèle Lafrance, who is a close collaborator on the trial we are running at Imperial. She has done survey-related study, retrospective interviews after having attended ayahuasca ceremony. So that's not psilocybin, it is the DMT-containing brew instead. And these people reported overall in that study decreased eating disorder-related psychopathology and increased self-acceptance and self-worth and self-love, all very important, also overlapping with what Lowen was just referring to with a person with a ketamine experience. Improved ability to process difficult emotions and memories, insights into illness, and so on. So these things pointing towards potential for that. We did a prospective survey, so we are doing a lot of online global surveys related to psychedelics, both macro, micro dosing, different aspects in ceremonies. Now we have 5-MeO, DMT, specific surveys. We have a range of these surveys, and we also have asked there whether people suffered eating disorder, and when zooming in on those in these surveys, we can see that people undergoing psychedelics, that depressive symptoms are decreasing and psychological well-being is increasing. So remember, this is prospective, so it's a bit better scientifically than retrospective. It's still is completely uncontrolled, and it's naturalistic. It's people out in the wild. You don't know what doses, and you don't know. We collect information about the setting, and also about the doses, but there's a lot of uncertainty and a massive variation in data. The good thing about this kind of work is that we can get up in numbers and actually collect data for quite a lot of people. This is not for that many people, because they're the ones specifically who had a self-reported eating disorder that were sort of pulled out for this specific analysis here. Interestingly, and in very much aligned with what Matthias was mentioning earlier, that the depth and the nature of the experience, also that we can also measure by having scales that people fill out online relating to this experience they go through over the time of the study, that in this case, emotional breakthrough, which is a scale we invented at Imperial that we have validated and are using, it's very good at predicting, sometimes better than the mystical experience questionnaire at actually predicting the clinical outcome. And also in this survey, we could see that the depth, the degree of emotional breakthrough also predicted the beneficial effects in the survey. Then in terms of figuring out how well received would it be to initiate a study with psilocybin, for instance, a psychedelic intervention in this population, there have been work done to try to get a sense of how positively it would be met. And overall, without going in detail with these numbers, people are pretty open, people suffering anorexia, to give it a go and to be positive towards conducting that kind of research. So it's obviously important that it's not just us sitting at an office somewhere thinking that that's a great idea. It's also a good idea to actually ask the people suffering. And we did that also ourselves in public patient involvement, PPI, which is something we do in most of our work, should be all of our work. I think sometimes we haven't done it, but we tend to do it, so that we involve people from the community with the conditions, as mentioned, in order to, and we did that in some online focus groups, and asked about different things. And there were some of the issues that they were struggling with in their normal path through the treatment system, that this over-focus on the weight recovery was for some quite off-putting and actually a difficult barrier to cross. So interesting themes came out of this PPI work. One patient said, I feel like psychedelics drug might be really useful in helping people integrate those two sides of themselves into one, taking anxiety away from having those thoughts and just accepting it is something that I can see as being a good outcome for this kind of therapy. So again, quite sort of positive and supportive towards doing this kind of work. So we are setting up, we're not just setting up, we are running it, and we're halfway through the trial, almost halfway through. The primary aim is to assess the feasibility and efficacy using psilocybin-assisted therapy for anorexia nervosa, and then also to determine neural mechanisms involved in this treatment. And they are getting 3 sessions with different doses, so I can't reveal the exact design because that would be wrong. And there are 2 MRI scans involved, and there are 5 different sessions with EEG. Here's the sort of overview of how it's designed, and you can see the different symbols representing different measures, EEG, MRI, and so on. And so there are 3 dosing sessions, and then the MRI baseline and towards the end, and there are 2 weeks between the dosing sessions in this design. And you can see that it's a lot of work. I mean, everybody who has been involved in this kind of research know it is a lot of work to basically recruit and screen and get patients into these trials. Although there's a great interest, there's a lot of reasons why people might not qualify. A lot of the people who responded in the beginning of this trial were men who wanted to be treated for depression, because we have done a lot of work with depression at Imperial. So they were just like trying to get in there in an anorexia trial. So they obviously had to be sort of rejected and disappointed, unfortunately. And then just a lot of people not fulfilling the very, very strict criteria. In this trial, people need to be involved with a proper NHS-based mental health care team for the eating disorder in order for it to be safe enough, in our view, to run that trial. So that makes it more complicated for us to run the trial, but then there's a direct dialogue with the treatment teams. So you can see that only 3% were actually enrolled in the study from the people who were going into the screening phase. And also, just to update you, so I think we have done 8 patients now in the trial, and the aim is 20. So it's a small pilot trial. Johns Hopkins are in parallel running their own trial, and we just contacted them the other day to see how far they were, and they are a bit ahead, which is good to know. So they have done 14 so far in their study. Then a little bit about chronic pain. Their old studies suggested that psychedelics might be useful in pain related to cancer and phantom limb pain. Psychedelics reduce inflammation, possibly resulting in desensitized pain response. So there's this also that Attila showed earlier today, that psychedelics have anti-inflammatory response, and there's obviously a lot of inflammation going on in most chronic pain. There are mechanisms through relevant targets, 2A and so on, involved in these mechanisms. So that's another reason why it might make sense. The chronic pain and depression overlap in the involvement of brain networks. There are involvements of the insula, of the prefrontal cortex, amygdala, and so on in both conditions. And there are involvements of, again, overlapping brain networks and abnormalities within the default mode network in both conditions. So there might also be that sort of argument to put that there might be overlapping mechanisms by which the psychedelic treatment might work. And also by relaxing, reducing overweighted pain-related priors, which is sort of in agreement with Rebus model by Robin Carhart-Harris, who have moved from Imperial to UCSF recently, or last year. I'll speak more about that model tomorrow evening in the talk there, where I'll be talking more about imaging and depression work. But again, here it might be very relevant to apply that theoretical framework to chronic pain as well. And then there is, anecdotal reports on online forums, but they're kind of anecdotal reports on positive outcomes of psychedelics. So everything at the moment, I would say, is over the last decade kind of explosive hype. But it's still important to, obviously, to assess. And we have collected data in surveys as well from that kind of work. And there have been positive outcomes in headache work with psilocybin. So basically, in the survey work that Julia Bornman, who is the sort of PhD student running the trial together with others, she found all these activities, all these behaviors to be present in people who have been using psychedelics to self-treat pain and found it useful. So you could see here that people basically found improvements through psychedelic experiences for directly related to their pain ratings in this work, and also different things. I think I'll kind of go directly here to the design of the trial again. Without revealing too much, this is slightly simpler than the anorexia trial. There's only going to be 2 dosing sessions in this one, but there's also going to be both EEG, quite a lot of EEG, including during the sessions, which there isn't in the anorexia trial, and then there's also MRI at baseline and at a later time point follow-up. And then a lot of EEG. The EEG paradigms, Meg Briggs, who would have given this talk, is an expert during her PhD in Auckland in New Zealand. She, together with the team there, developed some very interesting paradigms where you can induce and measure plasticity in the brain using some EEG paradigms, and that is being integrated in all the work we are doing in all trials. So we are collecting quite a lot of plasticity data from EEG acquisition across trials, and that also sits in both of these trials that I'm talking about here. The main hypothesis, the pain trial is not regarded as a clinical trial because it's not mainly measuring treatment efficacy or safety. So the primary thing here is related to psychological flexibility, experiential avoidance, and then brain markers with EEG. So therefore, it's a bit of a simpler trial than the anorexia, which is a proper clinical trial that is aiming at efficacy and safety. So basically, there's an hypothesis that there will be a significant relationship between changes in psychological flexibility and the brain markers with EEG, and an increased acute dysregulation of brain circuits, which we can measure as complexity in the brain, and that's basically using a compression algorithm on the brain data by 2, I think, Israeli mathematicians, Lempel and Sif. So it's called LZ, or Lempel-Sif complexity, which basically is how much you can compress. So if you can't compress it very much, then it's because it's really complex brain activity. Then it has a high complexity score, high Lempel-Sif score. And that the increase, and we see that if you are in a diminished state of consciousness, in coma or other diminished state of consciousness, you have a decrease compared to normal awake consciousness in Lempel-Sif scores. In the psychedelic expanded conscious state, there's an increase. So we know there is an increase with these treatments. We have seen that now in several populations. And we here hypothesize that this increased complexity under psilocybin will be associated with our main psychological outcome, which is the expected reduction in experiential avoidance. And then there are some other outcomes. I don't know if I'm not actually running out of time. What should I then do? I can show the teams, because obviously it's not me doing these trials alone. We are a big group, so they're the people running the anorexia trial that is going well, and then the xylopane that we hope will go well, that there will be more people involved than the one listed here, and then we are some people who are sort of working across both these trials and other trials we are running at our center. And then a lot of very experienced therapists that are involved also in both trials and other trials we're setting up. We're also setting up an OCD trial, hopefully starting soon. And we are doing that together with Maria and Tim, who are in the middle. And they have set up an institute for psychedelic therapy in London. And so they basically hold and contain and support and supervise and teach therapists going into that program. And then we have this sort of win-win exchange with them, where those therapists are helping out on our trial, and then we are sort of paying them to supervise them very closely, so we get a very close containment of the therapy in our trials. So that goes actually beyond these 2 trials. But and then just to get all the different acknowledgements, then I have another slide where different people who have supported the center financially as well are listed over there. So yeah, thank you very much.